Uveitic glaucoma or glaucoma is a relatively common and serious complication of uveitis. Despite the availability of new medication for both conditions, still its management is difficult. The association has been credited, or first description has been credited to Peer in 1813 when he described a patient with, arthritis and developed uveitis and glaucoma, and then he lost his vision, and then the reports start to follow. The, uh, the prevalence, according to the literature, of glaucoma or patient developing glaucoma, patient with uveitis developing glaucoma, about 10 to 20%, and its incidence increases with chronicity of the disease, being 6 at 1 year from the diagnosis of the uveitis, goes up to about 27% at 10 years, and the Neary and his group, they found that the incidence of glaucoma or development of glaucoma is similar among different types of uveitis. However, Takahashi from Japan and his group, they found that it's more common with certain types of uveitic entities like sarcoidosis, herpetic anterior uveitis. Again, in our population in Riyadh, in King Abdul University Hospital, it's a large series. We found also that the development of glaucoma is more common with HLB27, positive 27 anterior uveitis, as well as juvenile idiopathic arthritis, Fuchs uveitis, and so on. So, yes, we need to keep in mind that development of glaucoma and uveitic entities is related to the uveitic entities also. You need to keep this in mind. And I will skip the risk factors because, I don't want to delay the next session. So age, chronicity, corticosteroid, severity of the disease, all these are risk factors for the development of secondary glaucoma in patients with uveitis. For example, age is very important. It's a young age. The disease is a disease of young age, but when it develops in old age group, the possibility of developing glaucoma is more possible or more likely, because that any insult to the anterior to the angle can decline or unmask the declining function of the angle. As well, the chronicity of the disease reflect the cumulative effect of the inflammation, as well as the chronicity of use of steroids, again, is another factor. Severity, of course, there are indices that when you see it, you expect that this patient is at risk for developing secondary glaucoma, such as posterior synechiae and patient with HLB27 positive uveitis. As you see here, 45% of them develop glaucoma versus 17 in patients with posterior synechiae compared to those without, and fourfold patient with HLB27 positive uveitis compared to negative one. So you need to keep this in mind. Pathogenesis also, I will note, there need 10 minutes or 15 minutes to discuss it, which is very important. I know our junior colleagues, they are in need for that, but for the time, or the sake of the time, I'll skip it. But there's an inflammatory condition or uveitis, there are biochemical anterior changes in the composition of the anterior aqueous humor. For example, in inflammation, there is increased proteins. The concentration of protein in patient, and normally in normal eyes, is about 1% of its concentration in serum. In severe cases, it may really resemble undiluted serum. So this will work as a mud and can lead to a blockage, mechanical blockage of the outflow facility, as well as the inflammatory cells there again can work as mechanical blockers also for the aqueous outflow, as well as the released cytotoxins that can lead to depopulation of the endothelial cells of the Schlemm's canal, of the trabecular meshwork, as well as death of these cells. Direct involvement in certain entities, we know that, like folks like herpetic anterior uveitis, and also the cytomegalovirus anterior uveitis, which we call it post-Schwarzman syndrome, there is a direct involvement of the trabecular meshwork with these entities. So again, it is a mixed corticosteroid, as we mentioned. So it's a mixture mechanism the mechanism is a mixture of factors that maybe each one of them by itself can induce elevation of the pressure, or the combination can lead to formation or development of secondary open angle glaucoma. The other type is the morphological changes, anatomical changes in the anterior chamber angle that can lead to formation of the anterior synechiae, whether with or without posterior synechiae, and lead to angular closure. And these are very important to keep in mind as a pathogenesis for the disease. I will not, this is, for example, a patient with HLV27, one of our patients, and you see the broad peripheral anterior synechiae and multiple laser iridotomies, and the aim is not to reduce the pressure here. The angle is already damaged, but the aim is also to restore the anatomy of the anterior segment. The management, again, it depends on the, I don't know, time is running very quickly when I stand. Management is, depends on the, it's very important to have a successful management to do a proper evaluation of the patient, not all from the glaucoma point of view, also as a whole. So you need to look very carefully to the history and signs and symptoms to come up with the proper diagnosis of the entity of the uveitis. Look for the visual function and what's the degree of visual function damage, or the damage in the visual functions. Slit lamp examination looks at etiology clues that can help you to reach the entity of your uveitis you are dealing with. Gonioscopy is mandatory. I cannot deal with any glaucoma without gonioscopy. So gonioscopy, again, to see what are the mechanisms of development of the glaucoma. Is it open angle? Is it with a perimeter block, closed angle, whatever? So you need gonioscopy to master gonioscopy and really to come up with a good evaluation of the angle. Fundoscopy also for clues, also to evaluate the stage of the glaucoma, is it with cup disc ratio, with the nephrobilayer, and so on. UBM also to study the ciliary body and the iridocornea angle. And if we do these things, we will come with a proper diagnosis that really will lead us to a successful treatment of the disease. So the treatment, again, one conception that we need to keep it in mind is very important, that control of inflammation is a prerequisite to anything for management, whether medical or surgical. So under treating uveitis with the corticosteroids to minimize the IOP, not evaluation, but elevation, the elevation at the expense of good control of inflammation is a false economy. False economy. You don't know. يعني زي واحد تاجر ما يعرف يسوي تجارته. You will gonna lose the function of the eye because of the inflammation, not from the glaucoma. So either way, you're going to lose the eye. So you do the proper job, control the inflammation, then deal with the side effects of treatment, and then you will have a successful outcome. Management, so again, we need to remember that 24 of adults, or majority, let us say that majority of patients with uveitic glaucoma, ultimately they will need surgical intervention. So we need to keep in our patients, 50% of them, they need intervention. And medical therapy, of course, beta blockers, psychoplegic, not less than atropine, adrenergic agonist, carbamazepine inhibitor, whether systemic or topical, prostaglandin analogs if the inflammation is controlled. And what we need to avoid is myotics, and you know why we should avoid these things. When we come to the surgical management, again, the important to know what is the mechanism of glaucoma. So in a pupillary block, you need to do a laser iridotomy or even surgical. Although when you look to the picture, they say the surgical iridotomy is frequently needed. In our experience, probably I remember that one or two of my career that I needed to go take a patient to go for surgical iridotomy. Laser subglottic has no rule in this disease. Trabeculectomy as well as non-penetrating trabeculectomy, this will touch them very quickly. So in trabeculectomy, in uveitic glaucoma the success rate is variable between 30 to 78 in 5 years, but we need to remember that trabeculectomy in ordinary glaucoma, usually there's increased inflammation, hypotony, and probably these and cataract formation. These are probably is more more in patients with uveitis. The tube surgery is another, trabeculectomy also, in Japanese group, they compared 100 cases of uveitic glaucoma to the outcome of trabeculectomy to another 100 cases with primary glaucoma, and they found that trabeculectomy with mitomycin C was less effective in uveitic glaucoma patients than primary glaucoma, and not only that, but also experienced more frequent cataract surgeries in patients with uveitic glaucoma underwent trabeculectomy compared to primary glaucoma, 60% to 10%. So this is very important to keep it in mind. In tube surgery, another also alternative if there is no space for trabeculectomy. And again, we need to keep in mind, this is a recent report that they say that tube surgery in children with uveitic glaucoma are independently associated with significant decrease in endothelial cell density. So we need to keep in mind this is a young age group, whether children or young people. So I will not touch this one, I don't like it. So in 1 minute, just to summarize, we have 4 publications or so, but we have good work in uveitic glaucoma, especially open-angle glaucoma and uveitis. So we have, this is just 33 eyes in this study, and as you see, of 21 patients, and deep sclerectomy is employed in these patients, and the majority of them were uveitic glaucoma secondary to VKH. And of course, the initial IB was 37, and vision is, as you see, counting finger to 20/20, and gonioscopy, it's a must to have an open angle superior at least, and one eye is pseudophakic, the rest are phakic, and previous surgery in 2 eyes, and the number of medication was 3 something. And preoperative evaluation, one point here I want to say, when you look at the literature, you will say that you cannot do surgery unless 3 months period after controlled inflammation. In our group, we don't stick to this. Once it is controlled, usually these patients having high IOP, so we go for surgical intervention as long as it is well controlled.
Dr. Obadan, can we?
Yeah, sure. Dr. Smith, you didn't talk to him at the back. Well, anyhow, so what I will do, technique is very simple, like the deep sclerectomy that we have done. We ran it quickly that we saw it, but this is in adulthood glaucoma. So in open-angle glaucoma, we found that even my colleague in uveitis division, they are happy with this procedure more than us. They say, yes, this is the answer of the surgical treatment for open-angle uveitic glaucoma. Next day, you don't see inflammation, you don't see shallow chamber, you don't see many things that we see it usually with ordinary filtration surgery and ordinary glaucoma. I mean, trabeculectomy in ordinary glaucoma. Can you pass it a little bit? Anyhow, so this is now oozing. This is the window. And then we'll remove, it's very important here, not as in childhood glaucoma, the presentation and the previous. Here, easily you can identify the floor of Schlimm's canal and remove it to remove whether the juxtacanicular meshwork, and then this is the, so I'll skip this one. So in post-op, again, continuation of the anti-inflammatory agent, and topical steroids tapered over a very long time, and antibiotic for a few weeks. Frequent visits because these patients, they might need manipulation post-op, like laser suture lysis or gonipuncture and so on. As you see here, 36% of them, they need the suture lysis. So criteria for of complete 6 or above 6 or less than 22, and qualified 22 or less with medication. And the success rate, as you see here, after about 3 or 4 years, they're ranging from 1 month, 1 year to 10 years. We achieved, I will not go to the, we achieved about 72% complete success, and the overall success about 94. Yes, of course, this is not, we don't achieve this success rate in ordinary glaucoma for one reason, not because this is simplest or simple than, or more simple than ordinary glaucoma, but because they are taking more care compared to ordinary glaucoma. So frequent follow-ups and so on, and monitoring them very closely. So when we looked, none of them lost their vision due to the procedure, and Kaplan-Meier survival curve after 22 months, all of the patients had smooth post-op course, and complication only one. If Dr. Smith is here, there's a major thing that shallow anterior chamber or flat chamber, or extracellular inflammation is not seen in this series. And the only thing that this patient will have one long-term complication, the hypothalamic merculopathy. This is one of our cases, and he is a medical student in your state, and he fortunately was followed by Dr. Scott Smith there when he was there, and his hypothalamic merculopathy improved or corrected with 2 or 1 or 2 autologous injection, and the patient kept following with me. Last time saw him probably a few months. I see him annually, and he's doing great. So thank you, Dr. Scott. And finally, I will just conclude that this is the studies, international studies. They are small because it is rare, but when you look, we can learn something here, that the overall success rate here in different hands, different type of pathology or patient, it is comparable. So this can tell us the one very important point, which is the predictability of the outcome of this procedure. So in conclusion, glaucoma is a common and serious complication of uveitis, and glaucoma should not be an obstacle for aggressive treatment of intraocular inflammation. This is a very important point, and controlling inflammation is, as I mentioned, a prerequisite for the success of any procedure you do, whether you do deep sclerectomy, trabeculectomy, tube surgery. It's mandatory to really control the inflammation first, otherwise nothing will be successful. And we and others, they have shown that deep sclerectomy is effective with high safety profile and open angle uveitic glaucoma. And thank you, and I apologize for that.